Onc Live Insights is a video editorial program produced by Onc Live.
So there's going to be some different discussions, obviously, when you're talking about selecting treatment. Number one, it's important about knowing what stage the patient is. In that setting, we only have limited therapies in the early stage setting. Whereas if you're talking about metastatic disease, that's a little bit different. There we're utilizing more molecular marker analysis as well as chemotherapy in conjunction. We usually give the two together regarding biologic agents, and the choice of biologic agents is dependent upon what the mutation analysis shows. So there are two very different discussions, I would say. It just matters based upon what your goals of treatment are and what your stage of disease is. If we're talking about types of treatment options, at least for metastatic colorectal cancer, actually we have very few treatment options that are oral. So there are actually there's a lot of limitations in regards to treatment for colorectal cancer. So even though one part may be oral, the rest is all intravenous. It's more of a discussion about do they want, what type of catheter would they like in order for chemotherapy administration. I think that's also a point of discussion. I like to ask my patients, what do you like to do as a hobby? Do you have young children? Do you like to do fine handwork? Are you kind of very active, outdoorsy? Maybe sometimes then, the PICC line, which is an external line, is not ideal for the patient. Whereas a portacath, which is underneath the skin, is something that allows the patient a little bit more, he's not so limited in regards to what he needs to do. However, that has its own limitations as well, because then you have to have, basically, we don't like our patients to touch the ports themselves in regards to chemotherapy administration. Once the chemotherapy has been completed, we like them to come back into the hospital, which is a second trip, and sometimes that's inconvenient for the patient. But also they have to understand that if that port gets infected, obviously they're at risk for getting a severe, basically a bloodborne infection, bacteremia. So those kind of points of discussion are very, very important. Not only choice of chemotherapy, but the type of administration of chemotherapy, the various schedules of chemotherapy. There's got to be a lot of discussion going on. And especially if you're in an academic center where basically your infusion suites are open maybe Monday through Sunday, 7 days a week, whereas in the community practice setting, they're only open Monday through Friday. So then for most of us, for colorectal cancer, we have 46-hour infusions for chemotherapy, and then that means that that individual is only able to come in for chemo basically Monday, Tuesday, Wednesday, because then he has to get disconnected on Friday. So it's not convenient for him to go to necessarily a community center if he's hoping to have chemotherapy on Thursday, Friday, or even Saturday, Sunday. So those kind of things do have to be taken into account, as well as the fact that some patients will suffer from fatigue. Obviously, once the chemotherapy has been administered, then you have to take into account basically how it impacts your job, how it impacts your social life. We have a lot of patients that enjoy, once again, being outside and socializing with friends. We want them, obviously, to maintain a very normal lifestyle as much as possible. I think at the end of the day, it makes them a better patient and they tolerate their chemotherapy better. But you really have to go through all those various points to learn about the patient and whether or not they have a social support system. Obviously, an individual living on their own, especially if they're elderly, it is at a disadvantage, unfortunately. We have to be very, very careful with those patients in regards to toxicities of therapy.
Treatment of colon cancer has gotten more complicated. There are more drugs, there are more choices. We have to have genes and other stuff to make decisions. When talking with a patient about choices, we all have our favorites. We have our kind of mainstream approaches to things. And so most of us adopt those kinds of strategies. We're most comfortable with the treatment choices. If A and B are the same and we're more comfortable with A, just use A. And so it simplifies things. That doesn't mean don't tell patients that there's a B, but you explain why. So that's the education component to it. And as you talk with patients, so simple example, Folfox versus Capox. So Folfox is a pump, Capox is oral, right? The capecitabine part of that is oral. So what I generally do is start by describing the pump. It's a standard, and here's how it works. You come every 2 weeks, we check you out, we do a blood test, you stay in a chair for a few hours, we give you drugs, and then you go home with a portable pump that you'll carry for 2 days. At the end of 2 days, a nurse comes to your house, disconnects it, and then you're 12 days off. And then I'll say, or behind curtain number 2, we can do all of that stuff that's in the pump in a pill form. And you never know what patients are going to say. Some patients are like, no, the pump seems right. I know I'm getting it. IV's got to be better than oral. Others are like, why would I ever do the pump? I'm going to do the pill. So those kinds of things help them know that they're part of the decision making. And also, when they choose one, know that there's another choice.